moving on to the next topic, non-toxic goiter. A non-toxic goiter is defined as any benign non-inflammatory enlargement of the thyroid gland that is not associated with hyperthyroidism. The causes of non-toxic goiter can be broadly divided into diffuse and nodular enlargement, which roughly lead to the respective entities of endemic or diffuse and sporadic multinodular goiter, each with their own pathogenesis, risk factors, and management strategies. Let's start with endemic or diffuse goiter. Strictly defined, endemic goiter occurs in more than 10% of a given population. However, the only known cause of endemic goiter is dietary iodine deficiency, which predisposes people predominantly to diffuse goiter from persistent TSH stimulation, leading to a diffuse follicular epithelial hyperplasia. In effect, the terms endemic goiter and diffuse goiter have functionally become synonymous. It is estimated that more than 2 billion people worldwide are exposed to iodine-deficient diets. In iodine-deficient population, a palpable goiter can be detected in up to 40% to 90% of individuals, and hypothyroidism can be found in up to 50%. The risk of goiter and hypothyroidism increases proportionally to the severity of iodine deficiency. There is a female predominance in the prevalence of endemic goiter, approximately 2 to 3 times higher than in men, and its incidence increases by age group due to its environmental etiology. The morbidity and mortality from endemic goiter are due to its association with chronic untreated hypothyroidism and cretinism, as much as, if not more than, the local effects on the neck due to its size. Instituting proper iodine supplementation in iodine-deficient populations has been shown to be an effective strategy for decreasing the incidence of these diseases. The next is the non-toxic multinodular goiter. Sporadic multinodular goiter is the most common cause of non-toxic goiter in the United States and other developed nations with iodine-rich diets, with an incidence of approximately 5%. Although there is a known stepwise pathophysiologic process in which iodine deficiency can first cause diffuse follicular hyperplasia and subsequently stimulate nodular formation, the causes of the majority of sporadic multinodular goiter remain unknown. The incidence of multinodular goiter increases with age, probably paralleling the age-related incidence of thyroid nodules in general. The next is the substernal goiter. Substernal or retrosternal goiter is defined broadly as a goiter with a significant proportion of the gland extending inferiorly through the thoracic inlet and into the mediastinum. The incidence of substernal goiter is estimated at 0.02% in the general population, with 60% occurring among patients who are over the age of 60 years. There are a number of subtypes of substernal goiter. The most common subtype extends into the anterior mediastinum. The second subtype extends posteriorly to the great vessels, trachea, and auditory laryngeal nerves, sometimes crossing over to the contralateral neck. The third and least common subtype is the isolated mediastinal goiter with no connection to the normal cervical orthotropic gland and with unique blood supply from the chest. Substernal goiters are more likely than cervical goiters to be associated with local compressive symptoms, including shortness of breath or orthopnea and dysphagia. This is because the mediastinal extension of goiter pushes against and compresses the normal thoracic inlet structures, trachea, esophagus, vascular structures, within a fixed bony space bound by the ribs and vertebrae. Tracheal compression is of particular concern, as minor degrees of goiter enlargement and resultant narrowing of tracheal diameter can lead to dramatic reductions in ventilatory flow, which is explained by the Poiseuille's law, in a relatively short period of time. In contrast, primarily cervical goiter are often capable of dramatic growth without causing significant compressive symptoms due to the expandability of the surrounding cervical soft tissues. Interestingly, vocal cord paralysis from recurrent laryngeal nerve compression is extremely rare, and the presence of vocal cord dysfunction should raise the concern for malignancy harbored within the goiter. Now, if there is a presence of the non-toxic goiter, how do we work up for the case? The workup of non-toxic goiter consists of thyroid function testing to rule out hyperthyroidism and imaging studies to assess for the goiter extent and presence of nodules. The mainstay for thyroid imaging is NAICS ultrasound, which offers the highest resolution description of thyroid size, of volume, presence or absence of significant thyroiditis, and characterization of thyroid nodules. As stated in the American Thyroid Association guidelines, every nodule at least 1 cm should be evaluated for suspicious sonographic features on an individual basis, and FNA should be performed preferentially based on suspicion for malignancy. Cross-sectional imaging with either CT or MRI is essential for the assessment of and preoperative planning for substernal goiter, and is indicated for any patient with significant compressive symptoms and or sonographic evidence of inferior extension past the clavicle. Cross-sectional imaging is useful because it provides information about the degree of tracheoesophageal deviation or compression, laterality of dominant substernal lobe, inferiormost extent, anterior versus posterior pattern of extension, presence of crossover to the contralateral chest, and the presence of a separate intrathoracic rest. Unless there is concern for malignancy, the need for contrast enhancement is typically unnecessary. Now, after the workup, the management options for non-toxic goiter generally consist of non-operative surveillance, TSH suppression with thyroid hormone supplementation, RAI ablation, and thyroidectomy. Small non-toxic goiter generally can be followed expectantly with periodic thyroid function testing and neck imaging. TSH suppressive therapy with LT4 is often employed by endocrinologists as the first-line option, particularly for smaller goiters. The results of several large-scale trials are somewhat mixed but do appear to show goiter size reductions in about 30% of patients. However, these results must be balanced against the drawbacks of therapy, including the need for lifelong suppression and the long-term effects of subclinical hyperthyroidism on the heart and bone. Radioactive iodine ablation can reduce goiter size by up to 50% over a 1-year period, and it is an increasingly popular treatment option in many developing countries where access to thyroidectomy is limited. However, the effect of radioactive iodine is gradual. Acute transient thyroiditis can occur, which may exacerbate local symptoms and is ineffective for large goiters. The absolute indications for thyroidectomy in non-toxic goiter include local compressive symptoms, substernal extension, which often present with compressive symptoms, presence of nodules suspicious or diagnostic for malignancy in which prolonged ultrasound surveillance would be hampered, and patient preference, assuming that the patient is otherwise an acceptable surgical candidate. The extent of thyroidectomy, specifically unilateral lobectomy versus total thyroidectomy, can be tailored to the individual patient and goiter scenario. Total or near total thyroidectomy is typically the procedure of choice. Subtotal thyroidectomy is associated with an unacceptably high rate of recurrence in the long term, more than 50% in some cases. However, a unilateral lobectomy may suffice in certain scenarios, such as a single-site dominant goiter with a relatively normal contralateral lobe and in patients predicted to have poor adherence to daily thyroid hormone replacement. Thyroidectomy for substernal goiter presents a unique challenge depending on the amount and pattern of requiring partial or complete sternotomy. Most substernal goiters can be resected via standard cervical thyroidectomy incision because the majority of substernal goiters are anterior and extend inferiorly to a point no lower than the superior aspect of the aortic arc on cross-sectional imaging. These goiters can readily be retrieved via cervicotomy with proper neck extension and patient positioning. On the other hand, goiters extending further inferiorly than the aortic arc, extending posteriorly, and or crossing the midline from the dominant side are significantly more difficult and likely require sternum split and partial or even total median sternotomy. Thoracic surgery assistance is useful, especially for the more difficult substernal goiters requiring sternotomy or other mediastinal access.